and globally. All of you are important stakeholders for this important subject. To the presenters and the moderators, we really appreciate your time taken from your busy schedules to help us unravel the coming of age and what we must do. We have a very exciting session this afternoon, and we will start with our students. Most of us believe university students do not have major issues, especially with COVID-19. So I think you will get insights of what are some of the struggles they are going through. Secondly, we will have a cultural practice called vaginal practices coming from Mombasa County. I think that will really engage all of us. This will be followed by our vision for adolescents, policymakers, and as advocates. And finally, we'll even have our holistic experiences in addressing HIV. And we will have the Honorable CEC, Dr. Mbai, who will be talking to us about championing against teenage pregnancy in Murang'a County. I will finally come back and do the wrap up, and I hope I will meet your expectation. But that notwithstanding, I want to have a few housekeeping rules. Each of the presenters must stick to the time allocated so that we have enough time for discussion. So they shouldn't exceed 20 minutes. The moderators, do not worry, I will be the rapporteur for still this session. But between the two of you, please decide who will actually address introductions and who will address the Q&A section. If you are not sharing a PowerPoint and you would wish to present yourself, you can then snap on your video. If not, we will listen to you. After each session, ample time will be given for discussion, and particularly this evening, because we want to actually have a good way forward. If you are not going to have your question posted on the Q&A, which is our preferred method, and you must speak, please raise your hand. But however, we are requesting only one question per person, and please be concise. The program, I think, has been put up, so you are actually reading it as we are waiting for participants. Take note, there are CPD points for the healthcare providers who are logged in. And for those who are not healthcare providers, we haven't left you out. There will be certification. But we also request, before we certify you, that you may actually give us a response as to how you have found the symposium in totality for those who've been with us since Monday, or for those sessions that you have attended, so that tomorrow we can actually improve on what we are offering to you. I will now take the honor to actually invite our two moderators, Dr. Richard Aya and Korir, to actually take us through this afternoon. Thank you very much.
Thank you very much. Good afternoon, ladies and gentlemen. My name is Keegan Korir from the United Nations Population Fund, UNFPA. I'll be moderating this session together with Dr. Richard Aya. Perhaps, Dr. Ari, you may just want to quickly introduce yourself.
Yeah, good afternoon, everyone. So this is Richard Aya from University of Nairobi, School of Public Health, and I'm pleased to be with you this afternoon. Thank you, Dr. Key.
Well, thank you very much, Dr. Ari, and we shall be co-moderating this session, a very, very exciting session. So we just want to welcome you to sit back and tune into this very, very wonderful discourse that you're going to be having with a team of professionals working in the sector alongside the upcoming team made up largely of the students in the medical fraternity. Again, very well bearing in mind that we are on the last day of this very interesting Adolescent and Youth Symposium that has been made possible courtesy of the Kenyatta National Hospital. Basically, we are going to be delving so much into the way forward. What is the way forward in terms of advancing some of the components of adolescent and youth health that are very critical to us in terms of taking care of this very important generation going forward. So without any much further ado, ladies and gentlemen, we were going to start with the two sessions. We have the first bit, which is going to be looking at the perspective from the students. We want to hear the voices of the students during the COVID-19 pandemic. And this is going to be brought to us by none other than Mwangashi Michael, a year 5 student. Michael, are you with us?
Yes, I'm here with you.
Thank you very much, Michael. You want to talk through the perspectives and voices of students during the COVID-19 pandemic. You have 10 minutes, but perhaps you try to, if you can take it under that, so that we have more time for interaction with the people who are joining us. Over to you, Michael.
Thank you a lot, Dr. Good afternoon, ladies and gentlemen. My name is Michael Malomba, level 5 MBCHB student. And first of all, I'd actually like to thank you for this opportunity to be able to speak on behalf of my age mates, as I actually belong in the group of the youth. Because of time, I'd very much like to dive straight into it and start off by saying that usually the assumption is that A students usually have no problems, but as we shall see during this presentation, these challenges are equally real, especially during this COVID-19 time. As I usually like to say it, COVID has actually made people realize that we are all equal when health and everything alike comes to play. Next slide, please. So for this presentation, I'd actually like to focus on 4 major things. That is 1, poverty, mental health and drug abuse, GBV, as well as sexual risk behavior, as we can see from the bottom right. Next slide, please. So I'll immediately dive into poverty, and from a student's perspective, I'd actually like to make us, or rather put us in the shoes of a university student. So on the left-hand side, we have a measure, or rather the normal life-to-life living of a student pre-COVID, and on the right, during COVID, or rather after it actually started. So as you can see, during pre-COVID times, students could actually have 3 or 4 meals per day, but now they actually end up having less than 3. Some of them even have just 1 meal per day. From the left side, you actually see that students, some of them were actually accommodated within the school premises, but now most of them are actually forced to stay at home. And as we all know, not all of them are actually have the luxury of having a room to themselves, and so they don't have any privacy anymore. Looking at the pre-COVID side once again, we actually see that us as students, we usually have help coming from HELP, the Higher Education Loans Board, which actually gives us the funds to be able to take care of ourselves. Now looking at post-COVID, there is no money and literally you cannot do anything. During pre-COVID times, again, we're looking at students who are actually in the school premises, had access to light, electricity throughout, but reality is some of them are actually gone home and they don't have the luxury of electricity throughout. And finally, on the 5th one, I'm looking at the poverty of the mind, because we do know that all work but no play makes Jack a dull boy. So we used to enjoy our sports, but now in the essence of actually having to social distance, that is lost. Next slide, please. If you actually look at it from the national level, we can actually see that poverty hasn't only spared, or rather hasn't only gone rampant among students, but these are some of the things that some of us, even as adults, or rather people in the working field, can actually relate to. But more so coming back again to the student level, we are educated, but once we actually leave university, there is no employment for us. There are no jobs for us anymore. Looking at it, we can actually recall that recently the fuel prices have actually gone up. And this actually translates to the transportation costs, not necessarily for taxi services, but even for necessities. Like if I could actually take you to the top right-hand corner where you actually see bread. Recently, bread has actually gone up by 5 shillings. Bread is no longer 50 shillings. And this can also be attributed to the fuel price, because money is needed to actually transport these goods. And with rising prices, rise in such commodities. And again, we can't move as freely as we actually could earlier on, because now the matatu operators and even the taxis actually have to make their cut. So the price is actually passed on to us as the consumer. Looking at tax, most of us are actually looking to explore the digital space, but as we have learned recently that even in the digital space, we are now actually going to be forced to pay taxes. So how exactly are we going to move? How exactly are we going to come up if this comes, or rather this tax is introduced? Taking you to the right-hand side, we look at rent. Not all students actually are accommodated within the university premises, and so we are actually forced to seek shelter near the school. And as we know, not all landlords are quite encouraging, or rather quite inviting to us as young people. And so we actually find that the rent is too high for us. For some places, the rent has gone up because the landlord also has to meet his own goals. And now looking at the medical bill, something I think all of us can actually relate to. With this COVID-19 pandemic, we've been finding ourselves in WhatsApp groups where we actually have to contribute for one another. And us as students, it's that assumption out there that in the medical field, you know, you are a student, so one way or another, you actually have money. So we actually find ourselves in this kind of WhatsApp groups, and we're also forced to, you know, contribute to people we know, people we love, but really, do we have that ability to contribute? Just a question to ask ourselves. Next slide, please. So basically, what are we trying to say? That we literally have no source of income. We cannot afford a loaf of bread with that 5 shilling increment. And right now, it's even hard to afford the affordable houses, which when you actually listen to it is quite ironical. Next slide, please. That is an image of us just deeply thinking, stressed, and wondering what next. Next slide, please. So
Michael, just you perhaps just wind up so that we can have more time for conversation. Thank you.
Okay, I'll try to wind up and be as brief as I can. Thank you for that reminder. So I'll move on to mental health and drug abuse. So this is basically a story of a young person named Philip, who's actually my friend. And Philip is actually my colleague in medical school, and we joined in together in 2016. And Philip had this habit of actually smoking weed leisurely, as he would put it, maybe 2 blunts on Friday and maybe 1 on Saturday. But now, fast forward to 2020, Philip is actually smoking more, because initially Philip used to smoke to actually be able to cope with his anxiety. But right now, with the anxiety of actually what's happening all around, he's smoking more and more for him to actually be able to keep up and actually be able to go out there and say, like, you know what, guys, I'm actually not anxious. I can actually deal with this. So he's actually doing this behind closed doors using marijuana. And if you look again to Philip's life, his mom, or rather he comes from a single parent family. The mom lost her job during COVID. And now Philip also has to deal with the fact that he doesn't have enough pocket money to take care of his needs. The distance brought about by COVID-19 and the lockdowns meant that he wasn't also close to his loved ones. And this ended his 3-year relationship with his girlfriend, meaning he's now lonely. Again, there's medical school to actually keep up with. And now with everything being online, there's the whole idea behind Zoom fatigue, where you're seated in one place for quite a number of hours, just listening to lectures, and it can be stressful. And as we can see there, Philip is actually on the brink of just saying, this is enough. Next slide, please. So basically, what is he trying to say using some of his illustrations? So what's the point of trying to learn during COVID? Uhuru, the president, will probably bring another lockdown, and then I'll go back to square one. It'll just be me and my weed. Oh, and I miss my ex. If not for COVID, I will still have her. This is literally Philip saying, I am hopeless. I have no hope. I'm in despair. I can't stay home every day. Mom is always complaining about money. I don't even get enough pocket money as well. I need space. So this is Philip saying, I don't have money to take care of my own needs. I don't have my own privacy. And the last one, you know what, bro? Weed makes me think straight. At least I can play good to get money for it. I'm sorry, I can't see the last part. Don't know what I'd do without it. So basically, this is Philip saying, I'm addicted to weed. Next slide, please. And just to cap it all off, this is what he says. I have nothing at all to do. I don't even have the energy to try. I don't need anybody, or maybe nobody needs me. He actually chuckles as he takes a puff. All I know is I'm as high as I need to get, and I'm loving this stress-free life without the struggles. I just forget my troubles. See, bro, the power of weed. Next slide, please. We'll quickly jump into sexual risk behavior, where from statistics gotten from NASCOP, it was actually discovered that 332,208 teenage pregnancies actually came up more in comparison to the previous year when the schools were actually closed because of the virus. And basically, what is this actually trying to say? That these teenagers actually have free time, so they can actually explore, they can actually get cheated into doing some things, which is not exactly a picture that we want to paint of our country. Hence, the whole idea of the flag right there. And the question we need to ask ourselves is, do we have a National Sexual Health Day with a customized curriculum for adolescent and youth health? Are we truly protecting victims of sexual health or protecting the sex predators? Because as we know, most teenagers, once they do get pregnant, they are usually chased to be with the person who impregnated them. Yet, it might actually be as a result of rape. Again, how do we reinstate young teenage mothers in the academic world? As we all know, most teenagers usually find it hard to go back to school. They're usually married off, and yet and when this happens, they usually end up losing a lot on their education. So at the end of it all, they end up being dependent. Next slide, please. So basically, the whole idea of sexual risk behavior actually revolves around transactional sex, and there are usually motivations for this. One of them is usually economic survival, especially coming from parents. You know, you are at home, COVID has struck, there is no money, your parent can't give you anything, and then it's all the idea is, you know what, you can go out there, get a man, sleep with him, and he can actually give you money so that you can feed us. Again, for some of these teenagers who actually don't live with their parents or guardians, they actually need to make ends meet. And some of them find themselves in prostitution because they need to make ends meet. They need food on the table. Some of them can't even afford to get pads. And so this actually becomes a motivation for them. Another one is actually social media, and pressure influence. Because whether we like it or not, the world is actually becoming a social village, if I could put it like that. So we are basically almost always on social media platforms. So we look at Instagram models, we see them posting pictures in Dubai. You read with this girl, you see her posting pictures in Dubai, and you're wondering, how exactly did she go there that fast? Then you actually follow up and see that she's posting a video with someone quite older, someone old enough to even be her grandfather. And it gets you thinking, can't I just do the same thing and find myself in Dubai as well? Again, there's the aspiration for upward mobility or status. So it's actually hard for you to convince a young person that, you know what, hard work actually pays. Because basically what is known, again, taking a leaf from Instagram, is that all I need to do is get with my senior, maybe have a bit of fun, and I'm up the ranks. So is this hard work really cut out for me? Next slide, please. So just food for thought, just a small story from one of my friends in campus. So she actually said that one random day as she was out and about with her friend, that her friend's periods just decided to show up, you know, as untimely as sometimes they are. And they actually had to hustle to get apart from some of the ladies that were around. And when they actually went to the washroom, they did find a dispenser that was actually full of the free condoms. And then the friend actually just told her, or rather echoed, "I wish we had searched for pads," which actually got her thinking, why are there free condoms yet no free pads in the public washrooms? Something we also need to think about. Next slide, please. Next slide, please. Hello, I'm stuck on the food for thought slide. Kindly move to, yes, thank you. I can see it. And finally, just a touch on the gender-based violence. So we will basically have a small conversation from an excerpt that I actually got from one of the WhatsApp groups. And from a previous alteration, one of my colleagues actually posted that. And basically what was coming up was that we should reflect on issues rape, sexual exploitation, sexual harassment in the workplace, and domestic violence. And just taking that small portion and doing a small research, we found that 45% of women and 44% of men aged 15 to 49 have actually experienced physical violence since age 15, according to the Kenya Demographical Survey. And according to an article by Nita Bala in the Thomson Reuters Foundation News, a national helpline supported by the Department of Gender Affairs reported 1,108 calls in the month of June compared to just 86 in February of last year. So we can actually see the increment in the number of calls due to GBV. Next slide, please. And using that chart, we can see that 41% of all criminal matters that were actually reported were due to rape and defilement during the period of March to April 2020, when COVID had actually hit. This is almost half of all criminal matters that were reported. So, you actually wonder, all this just happened from nowhere. Again, just a response to what the student had actually said earlier on matters relating to the rape and the sexual exploitation. One student actually replied and said, if my daughter came to me and told me she was raped, I'd be skeptical at first. Yes, before you murder me, hear me out. I'm a skeptical person by nature, and what compounds the problem is that women are mostly people who color the truth, so I wouldn't be initially inclined to believe her story if she claims to be raped. But there are set precedences for investigating rape, and the law is very clear on that. Next slide, please. Just looking at, or rather in addition to what that student had said, there was a memo from one of our universities here in Kenya, which was actually saying that in all 3 incidences reported last year, a clear case of recklessness on the part of our female students can be drawn. And among the recommendations that were given was, for female students, don't walk alone from city center at night, even in the company of other female students, to the hostels. Endeavor to actually use secure means like taxis or wait until it is daytime. But because of an uproar that actually came out of this, an apology was actually issued by the university. So basically this is saying that regardless of the time of the night, lockdown and curfew aside, it's not safe for a woman to actually walk out there. Now, should that really be the case? Looking at it, rape is the most highly underreported crime in Kenya, and it is estimated that only 1 out of 20 women in Kenya will report a rape, and only 1 in 6 will seek medical assistance. This is from CSI Nairobi, published in 2008. But the question is, has anyone asked about the risk of HIV, STIs, and unwanted pregnancies resulting from the unreported cases? Something to think about. Next slide, please. Just a continuation of what the students continue to actually say. I usually am very clear with my intentions, and if she resists, I will force myself on her. But if she doesn't work out, I'll persist until. So a whole idea of actually clear communication and assertiveness, where if indeed it is no, it is no. If it is yes, it is yes. And basically just something from a recap on what was actually said is we are 100% to blame for whatever is actually happening. And we need to educate ourselves and learn. Next slide, please. So exactly what do we recommend to actually deal with this? We need to demystify, normalize conversations about sexual health, safety, and autonomy. We need these gentleman clubs, such as Men of Valor, where men can actually come and talk about their issues affecting them, issues affecting the whole country, and actually even find for
Colleagues, I think we may have lost Michael along the way. But at this juncture, let me just take this opportunity to really laud his very wonderful presentation, highlighting, the very issues that are affecting the young people from the lens of the students, the issues around poverty, the issues that have escalated because of COVID, a lack of basic needs, including access to healthcare, drug and substance use, issues around sexual risks that are, young people have been predisposed to because of COVID-19 circumstances, and also last but not least, the issues around gender-based violence. I think let's keep the conversation going. I can see there are a number of questions which are coming up. Let's put the questions on the Q&A section. And I believe that at the end of the discussions, we are going to have an in-depth conversation and question and answer. So without any much further, perhaps is there anything that you wanted to highlight that has come up from the chat box?
I think, yes, a couple of points that have come out. One of them is, and I'm not too sure that it is for Michael to answer, but one of them is around what are the national initiatives around adolescent health? And then the other question is about adolescents going back to school, the policies around that. So I think we can hold them for later on.
Thank you very much. I think so without much further ado, ladies and gentlemen, I want to take this opportunity to welcome our next speaker, Beverly Miche, who's going to take us through vaginal practices. Karibu sana daktari. Daktari, over to you.
Good afternoon.
Good afternoon.
Afternoon.
Thank you very, I hope you can all hear me. My name is Miche Chepwogen. We prepared this presentation with Mufida Shabibi. We both work in the coastal region. I work in Kilifi and she works in Mombasa. So today we are going to talk about vaginal practices. Our main objective, next slide please. So our main objective is going to be to improve our knowledge on the existing vaginal practices, their complications, and the safe practices or recommendations that we came up with. Next slide. So outline, basically we'll define, we'll be able to tell you the types of vaginal practices, the reasons for the practices, the complications that arise from the practices, the recommendations, and finally we'll have our references. Though some of the references will be having it on the slides that we present. Next slide, please. So definition, these are the practices that comprise a variety of behaviors that women use to manage their health and sexual life. And it includes all efforts to wash, modify, cut, cleanse, enhance, dry, tighten, lubricate, or loosen the vagina, or the labia, or the clitoris, or hymen. This include a substance or material applied. Sometimes they could use liquid, sometimes they use herbs, or it could be things that they are ingested, inserted, or steamed, and the woman sits on it. Next. So we are going to give you the types according to the means of application or delivery and the specific products used. That is mainly if it's powder or dry herbs or liquids, or method of delivery, is it insertion or is it applied? So the first type is intravaginal cleansing with liquids, which include douching. Then we have insertion of dry substances into the vagina, either using cloth, cotton, or tissue paper. Some of the substances are also ingested with an intent to affect the vagina. And then we have the other type being the tightening and drying. That is through what you might have come across in the market. They are calling it yoni pulse or vaginal steaming or smoking. And this is normally done postpartum. Next slide. So then we have other types where the anatomical modifications are self-administered. That is, an individual cuts their introitus or excises and causes scarification with insertion of traditional substances into the cut that are later washed away. It also includes labial elongation, and other practices include decorative shaving, tattooing, and dyeing of genital hair, use of sex stimulants from gadgets to creams, and droplets to help tighten the vagina. Next. So these the types are also, the WHO did a study and they were able to classify the types of vaginal practices according to this table. I'm not going to go through it because it's just been explained on the previous slide, but we'll be able to share this presentation for further reading and maybe understanding what I didn't explain well on the previous slides. Next, please. So this was from a study that was done in Zimbabwe. They were able to classify according again to the types of substances that were used, the method of application, and the timing of application. Some substances were inserted either postpartum, or some of them were inserted after or before sex. Next slide, please. So the reasons that we came across while preparing this presentation were many, but among the ones that we listed include a preferred vaginal state, which related to cleanliness and the right amount of lubrication and tightness. Preferred meaning what the woman or the partner preferred. Then we had traditional norms that were being followed, either they were learned from the mother or the grandmother or the auntie or an older person. Then we had hygiene, that is some women believed that during menstruation they needed to insert their fingers or insert substances that they believed would clean the vagina. And it was also done prior to or following sex or during pregnancy. So, and then we had sexuality, which included drying or tightening of the vagina for sex preparation and also for sexual pleasure or enhancement, which WHO called it relationship security. So it's more of a woman trying to ensure that the partner does not go away or look for another partner. Then we have maintaining partner commitment. That was in relation to the males. That is to make the males commit to the females, and then increase confidence with their partners. This was mostly observed with females trying to do all this so that their confidence was increased. Then we had vaginal health or treatment of genital symptoms. So instead of seeking medical help, they would go to aunties or grandmothers or an older peer or just a traditional herbalist who would then give them substances that they would believe would clear away the genital symptoms. It was also used for prevention. It's also used by some women for prevention of infections and pregnancies. They believe that after sex, if they dosed or inserted certain substances into their vaginas, they would prevent a pregnancy or they would prevent infections. And the most common infection that was talked about in the studies or the articles we read was HIV. So then we had economic security for women who were involved in transactional sex. This included either women who were in a long-term relationship, but were in that relationship either for gifts or things they gained from that person, and also commercial sex workers, that is prostitution. Sorry for the repeat. It's to prevent infection and pregnancies. I'd already mentioned it. And then we had just to maintain the feminine identity from early adolescence. This was talked about in a study that was done in Uganda and Tanzania. And in Uganda, once one reached adolescence, they were taught how to elongate or rather pull their clitoris for feminine identity. Next slide, please. So this is a summary of why women actually do these vaginal practices, and they are classified mainly into cultural and social norms, and then subjective well-being, that is relating to a person. Why do they do this? So if you see that there is economic security and relationship security, which was mainly because of an individual, and then we had the cultural and social norms that believed these vaginal practices would enhance sexual pressure, was for hygiene reasons and fertility. Then next slide, please. So the complications that arise from all these vaginal practices, one of them included from the studies that were done both by WHO and other studies in Uganda. There's one that was also done in Kenya and one in Tanzania. The Uganda and Tanzania was combined between 2009 to 2010. And the complications that were picked were increased risk of HIV acquisition. This was because directly by causing abrasion and inflammation of the vaginal epithelium, leading to recruitment of HIV target cells. Then we had indirectly by disrupting the vaginal flora, leading to bacterial vaginosis, which is also a known risk factor for sexually transmitted infections and HIV. Next slide, please. Another complication, like I had mentioned before, there is increased risk of vaginal vaginosis, but then other diseases like pelvic inflammatory disease, sexually transmitted infections like Trichomonas vaginalis. Then we have infections that resulted from these infections resulted from epithelial damage and an increase in vaginal pH that were caused by these practices. There was also an increased HPV positivity of any genotype that was caused by these substances disturbing the local innate immunity or removal of the cervicovaginal mucus secretion that served as a protective barrier against the various genotypes of HPV. Next slide, please. So then we had lesions or swellings. This was a result of genital trauma when women decided to either cut themselves or cause scarification. So they would result in swellings and lesions or ulcers. Then long-term use of these practices, especially insertion of substances that tended to cause dehydration of the vaginal orifice, it would lead to sexual dysfunction because now this resulted in extreme dryness, which causes dyspareunia. Then marital feud, because the partner assumes that the woman has extramarital affairs and therefore is less attracted and aroused, and therefore causing the dryness, while in actual sense, it's the vaginal practices that have caused her to have this extreme dryness and dyspareunia. Next slide, please. So the recommendations were that we came up with from the studies and the articles and that we read were women should not, first we discourage most of the vaginal practices, and we advise that they wipe from the front to the back. They should completely avoid douching. They should ditch feminine hygiene products. There have been so many in the supermarkets, and there are so many even out there on social media. When you go onto Facebook or Instagram pages, you find people advertising vaginal steaming or use of yoni pearls or insertion of liquid substances that they claim they clean the vagina, or they enhance the tightness of the vagina, or causes lubrication, or have a certain smell that could be attractive to a partner. So we should also encourage women to eat probiotics, and then to maintain good menstrual hygiene, that is not staying with a pad for so long or having tampons staying for so long. Practice safe sex, that is use of condoms, and then perform Kegel exercises. As we had noticed before from the previous slide, some of these things were done postpartum because women believe that the practices actually would tighten their perineal areas, while in real sense, it actually dehydrates and causes dryness and a feeling of tightness that would otherwise been achieved by Kegel exercises. Then we also need to have our clients. We encourage our clients to visit the gynecologists for preventive and therapeutic care. There's a procedure that is called Cleopatra procedure. It originally came from Egypt. This is a procedure where the blood of the patient is centrifuged, and then platelet-rich plasma cells are injected, and this was to treat issues such as difficulty with orgasm, pain during sex, or inability to become aroused, or incontinence, that is urine incontinence. So next slide, please. This is just a summary of what we found out on social media of things that women are using to clean or tighten or lubricate or make their vagina swells. There's a link there that is from a Facebook page called Yoni Pulse. When this video is basically advertising pearls that they insert on the vagina to either clean or tighten. Probably if we could just play that, and then the rest we could pass through later. But that's the end of my presentation. Maybe I kindly request the host to just play the video.
Thank you very much. Is that video ready? Okay. Perhaps as we try to set that up, I want to just express my sincere gratitude to Dr. Mitei for the very wonderful presentation. I think this is really quite informative and a departure from, the narrow lens of menstrual health that I think most of us have become accustomed to. And basically, the connection that is coming out in terms of the gender stereotypes, the gender norms, and the relationship, with some of the vaginal practices are quite evident. The linkage with culture and what have you. But also, then we're also seeing the risk factors that are predisposed to women and girls, particularly issues around HIV, sexually transmitted infections, HPV, and also last but not least, the relationship as well, with gender-based violence, and also very much linked to the intimate partner violence. So without any much further ado, I think perhaps we may revisit the video later. But thank you very much for the wonderful presentation. Dr. Richard, do you have anything coming up in the chat box?
Yeah, so a couple of questions have been asked, and Dr. Shabibi, I think, has answered some of them. There was a question, and Dr. Mitei, you may want to just highlight that one about practices around economic security. So it's been partly answered on the chat, but you may want to just bring that out.
Okay, economic security in terms of commercial sex workers, but also people who are in long-term relationships, not really for the relationship, but to get gifts or privileges out of the relationship. So they would want to do these practices to be able to, lack of a better terms, seduce and keep the man and continue getting these gifts, or if it's for commercial sex workers, probably to be paid more.
All right. Thank you very much. For those of us who have questions, please feel free to post them on the Q&A link, and perhaps we can also still have time to have a conversation at the very end of the session. So at this juncture, ladies and gentlemen, I want to perhaps hand over to my co-moderator, Richard, to the next session, and then we can pick it up from there. Over to you.
Yeah, thank you very much. So it's my pleasure to introduce the next two speakers. So Dr. Sheila Macharia will be speaking next. So Dr. Macharia, if you're on, please come on. Dr. Macharia is a renowned public health expert. She's been a senior advisor with USAID for many, many years. And lately, she's now a consultant with the Presidential Policy and Strategy Unit, looking at areas around adolescent health. So Dr. Macharia.
Yes, good afternoon, and thank you very much, Dr. Aya. I had sent my presentation, so I'll kindly ask that it would be shared on the screen.
Yes, we are sharing. Just a minute, shortly.
Thank you. All right, are you comfortable with the setup? Dr. Kanudia, should I go ahead?
Yes, we are ready. Thank you. Yes.
All right then. Okay, so thank you very much, Dr. Kanudia. Good afternoon, colleagues and friends. And I want to thank the organizers for the opportunity to make this presentation, whose title is written there. It's a vision for adolescents as policymakers and advocates. Next slide, please. So this afternoon, I want to take us on a brief reflection where we look at global commitments that have been made for adolescents, and some of them, of course, are reflected nationally, and reflect on what we've heard the past few days, say something little about the policy environment, the need for the adolescent voice, and start a conversation about what has come through as the need for a different approach to address matters of adolescence. So next slide, please. So adolescent aspirations are reflected in many global and national commitments. At Kenya's independence, a commitment to freedom from poverty, disease, and ignorance was made. And as we can see here, the SDGs reflect these same challenges, committing to alleviate poverty, to create access to education, access to good nutrition, quality and timely SRH services, and further, they expand even to protecting the environment, which is important and an important future for adolescents. Closer to home, we have the African Union 2063 agenda that speaks to development and covers all of these areas. Recently, we have the ICPD Plus 25, which speaks to ending female genital cutting, early marriages, gender-based violence, and many other commitments. Next slide, please. So with that background, what has come to the fore? Over the last few days, we have heard that all is not well for adolescents. And there are situations that have arisen that some are not so new, but others are new. Many of these situations have been exacerbated by the pandemic. And we realize that this pandemic has brought unprecedented havoc to global and national health systems and supply chains, decimating the progress that development efforts have established over the years. This has not spared any sector, from tourism to agriculture to manufacturing, bringing a downward spiral to many hopes and dreams as jobs are lost and businesses close. And the necessary containment measures have resulted in school closure, bringing children and adolescents and youth home for extended periods of time. And in the midst of all of this, poverty and, quite frankly, despair has affected many families, many children, many adolescents, because of the new situations that they find themselves in. And as a country and as a globe, as we grapple about these things, and currently as we focus on adolescents, we realize that underpinning this is the reality that the post-pandemic recovery strategies are pressed on every side to meet the needs of the general population, not just adolescents. Next slide. So I'll go through the things that have been brought out by various experts, and I really must say that I've been very enlightened by a lot of what has been discussed, and kudos to the students who have made presentations and other of our young colleagues. So generally, these are the things that come across, that there was an interference with access to essential services, that there are concerns still about HIV amongst young people, and I know later that we will have a session on that, that the 95-95 strategy now for HIV takes into consideration that the first two, basically identifying that positive adolescent or young person and retaining them on treatment, was a real challenge in the 1990 strategy, let alone the viral suppression. Teen pregnancies have increased. We've got evidence on that. And schools are admitting adolescents in this situation, or adolescents who've actually had babies. And we need to ask ourselves, do schools have the requisite facilities to manage antenatal care, labor, delivery, all of that? Are they well linked to health facilities, to ambulance facilities? What about the nutrition of these pregnant girls as they come back to school, and their mindset? Are they ready to take on those challenges? Next slide. Contraceptive use by adolescents, still a matter for debate. Matters culture, should abstinence be there? What's the age of consent? We had a good engagement about the sexual debut and the reality that puberty is coming at an earlier age. Contributions from Professor Duarte, who talked about the need to look at data differently now, so that we can better address the sexual and reproductive health needs of these children, who actually start from 10 years to 19 years. And then the reality, which has been expressed by many, many people, that basic things like access to menstrual hygiene products reduces drastically when the girls are out of school. Next slide, sorry, yes. So we also realized there are new challenges in mental health. We saw that at the beginning of the year when schools opened and young people having troubles with their teachers and engaging in violence for some of them. But basically a lot of discouragement amongst the youth about their future. And the need, as was said by one of the experts, if you're going to have treatment facilities, you need a place where young people are. Mental health, a big concern. And the question is, are teachers equipped to respond adequately? Substance abuse, a continuing problem. And then what became a global pandemic, gender-based violence, that factors in the sexual gender-based violence, and that affected children, adolescents, and women. And suddenly, or more increasingly, home was no longer a safe haven, neither was the community. The non-communicable diseases, we were told that the other day, that more attention is needed because there are lifestyle changes that are really affecting the adolescents. And then nutrition. The access to food has become a bigger problem during this pandemic as poverty has increased. Next slide. So is it that we lack the policies to address all of these factors? No, not at all. We have very many policies in Kenya, and there I only give an example. And, based on recent work, we have a National Violence Against Children Strategy 2020 based on work done in 2019. We have the Adolescent and Sexual Reproductive Health Policy, and we had Dr. Anne Mwangi representing a new work that's been done on a community component. We have in education the 100% transition, of course, a new comprehensive-based curriculum in place. We have nutrition policies, we have policies around mental health, we have policies, a lot of them. And then currently, because of COVID and many other things, we have efforts to stem or address teen pregnancy by the Ministry of Interior, working groups being established in different counties with a view to addressing that. We have current efforts to end FGC because we have committed to doing so by 2022 under ICPD. There are concerns, of course, for the girl child and a growing realization that we need to pay attention to boys and to include them in these discussions. Next slide. We really need the adolescent voice because they know where the shoe hurts most. They're the ones who have questions about their education now and about home and parents, and when there's no money in the home, how things go south. The sexual reproductive health, how they feel. They felt horrible not being able to socialize. And then their interaction with substance abuse, their need for other things like sports and other skills, cultural practices, which adversely affect some of our girls all over Kenya. Boys were exposed to child labor because they were forced to go out and continue to be forced to go out to look for money. And as we've heard, to gender-based violence. And girls, as they expose themselves to risky interactions, either because they're being forced to work or they need basic needs. And the realization when there's no money at home, it is tough. Next slide. So what do adolescents want? They're not very complicated things. They want to be seen, to be really seen. They want to be heard, to be protected, respected, given opportunities, facilitated to achieve their dreams, and to remember that our individual social cultural realities affect their life's pathway. And also to accept that the digital age has expanded their horizons and their possibilities, and so they think very differently. Next slide. So what does it take to address adolescent concerns? And here I just want to touch on one example that has come from Migori County. And they have a strategy that they started in 2018 with an end date to 2022 to improve the health and wellness of adolescents and youth. It has successfully reduced teen pregnancies from 35% in 2018 to the current 21%. And how they did that was a partnership, a multi-sectoral partnership with various players. And so that they moved from a siloed approach to a multi-sectoral approach. And they developed a clear plan. They had a clear monitoring plan. Everybody had a responsibility from the Ministry of Interior to the Justice, to Transport, to Health, to Education, to Parents Teachers Association, to adolescents themselves. There's a sustainable financing plan, and the county itself put money. And where they started was by asking adolescents and young people, what are the problems and how can we address them? And they have had success. So they have taken a different approach and seen success. And I know later we'll hear from another county, and I am aware that even in Kilifi, they've tried something like this. Next slide. So what we are seeing and what everybody's asking is, at this point, therefore, what is it that we need to do differently? Because we have the ideas, we know that we need to somehow to do something different. But the reality is that we have a very siloed approach. We have the Ministry of Education looking after children. We have the Ministry of Gender. We have the Ministry of Health. We have the Ministry of Agriculture. We have different ministries, and these are reflected even in the county. So I want to just give an illustration here, and that's what I put there. If you recall the old way, when one was, putting up a building, you had your architect and you had to deal with your structural engineer and the mechanical engineer and the electrical engineer and the clerk of works. A truly exhausting and time-consuming approach. And currently, in a way, that's the way that we're dealing with matters to do with adolescents and to do with youth. And no wonder we are a bit puzzled. Next slide. So what is the new way of building these days? The new way is that you have a project manager. And this person oversees the architects, the contractor, and the crew, and the engineers, and the landscape, and the interior designing, all of those. And so they monitor, they see that the financing is done, they see that the results that you want are done, and it's a streamlined approach. It may seem light, but it does perhaps give us a glimpse into maybe we need to do things a little differently. Next slide. And so I put this out there, something that we can consider. You have been told that currently the matter of adolescents has come to the attention, of course, of the Office of the President. And there's a lot of thinking there with the recognition that the experts who are represented here have been doing a lot. And that there are laws and policies that exist. What perhaps is needed is a different approach. So the first is, which was alluded to by one of the university students, economic recovery strategies and resilient approaches now, post-pandemic, must clearly reflect adolescent and youth-centric approaches. You can't have a student who can't afford basic food or children who suffer at home because there is no money and they can't return to school. So could we consider having one entity that's responsible for adolescent development? And this entity would have a comprehensive sectoral representation, and I put some of the sectors there. And it would be an entity that, of course, establishes strategic partnerships, would reflect clear leadership and a voice for adolescents, not tokenism. In Migori, they had adolescents, and they have adolescents in the committee that's at the county levels that sits with the executive. So this entity would have adolescents and youth represented there because they know where it hurts and they have the solutions. And then establish a legal framework around that and, of course, finance it. What that would mean is that all the efforts that are currently siloed are being pulled into one entity that is responsible for seeing and monitoring and pushing to see that things are done. For instance, the enforcement of existing laws, as has been said by some people, enactment of laws where gaps exist, and all the things that pertain to addressing their needs. Basically, just bringing about efficiencies. Next slide. So I say to you that we have started a conversation. And what I'm asking is that, like everybody else, we need to act. And this is just to start us thinking. We have great ideas. The thing is, who is it and where is it that we will put all those ideas? And underpinning all of this is that we need to collate evidence. All the evidence we have amazing evidence, but perhaps we need to expand it a bit so that we can understand the needs of the boys and then create plans that are responsive and effective. And also that we can hold ourselves up to saying that we made this commitment and we are making some movement. And finally is to say that things are different now. Like one of the young people said, it's a global village, and young people are really looking at opportunities that are out there and they desire to have that. And it is possible. It is possible if we give it the attention and the energy that it deserves. Thank you very much.
Thank you very much, Dr. Sheila Macharia, for that enlightening presentation. Dr. Macharia has highlighted the importance of policy, the policy governance, and also talked about having good policy architecture in place to enable the various policies to fulfill the kind of outcomes that we're looking for. Keegan, Corid, any questions that you think we should take up now, just before we get
the
next speaker?
Yeah, thank you very much. I think one is that there's really great appreciation for the Migori multisectoral approach as a great model that's worth replicating and scaling up. But also, I think one question that perhaps Dr. Sheila can quickly respond to is whether we have the age desegregated data for the 10 to 14-year-olds, and also, what are her perspectives around inclusion of the sexual and gender minorities in conversations when you talk about adolescence. Over to you.
Thank you very much, Dr. Keegan. Under the HIV program, which I think Dr. Ruth Masha is going to talk about, we do have opportunity there for the segregated data. But what I think was being talked about is that concern, and I like this question, the concern for the very young adolescents then needs to be expressed through the health sector, not just in one particular area that concerns the adolescent. And the second question, sorry, Dr. Keegan, was?
It was the issue of the age desegregated data. You've covered that?
Yes, and there was a second one.
Yeah, the second one was actually the issue of inclusion and recognition of the sexual and gender minorities in conversation around adolescent health.
Ah, I see. What I'd say is that there are conversations that need to come to the table. They tend to be hidden and siloed in certain areas. And that's why you will have people who feel left out, at the end of the day. And so I feel that if there is a real valid representation of young people, not tokenism, and one then brings in the parents, because we have realized that we really in Kenya need the positive parenting, even the desires and needs of the young children can be brought in through the school strategies and the bringing in the community voices. Finally, what I'll say is that, as a country, we're not the only ones who are struggling with this whole business of how do we do this? And there are many countries currently who have actually set up commissions. And I know in Kenya, we don't like them because we always think, oh my goodness, not another commission. So let me just say that there are thought platforms that have been set up to precisely coalesce all of these questions that have been raised, and that cover a multi-sectoral, holistic part of the young person's life, and just bringing together. And they're really led by young people. And then they have the right policymakers at the table, backed by the right partners, or even private sector, faith-based, and the cultural leaders. And this is where the answers will be. So bottom line is to create the platform and then have the voices brought to bear. Thank you.
Thank you very much, Dr. Macharia, for that. We'll move on to the next speaker. The next speaker is Dr. Ruth Masha, who is the Chief Executive Officer of the National AIDS Control Council. And she will be presenting on expert sharing in HIV. So, Dr. Masha.
Dr. Aya, I think we could go to Honorable Mbai as we try to get Dr.
That's fine. So that's fine. So if as we wait for Dr. Masha to come in, Dr. Joseph Mbai, who's the County Executive for Health, Murang'a County. If you're in the house, you can begin to present. Thank you very much.
Okay, thank you very much, team. Good afternoon. Can you hear me?
Good afternoon, we're with you.
Good afternoon to you.
Afternoon.
Okay, thank you very much. Joseph Mbai here, speaking from Murang'a County. I must say that this discussion has come timely because adolescents and youth are our people and we must support them. And I just want to give an overview of the championing we've done against teenage pregnancies in Murang'a County. And This is a program that we started about 2.5 years ago because of the issues that we had seen of teenage pregnancies, young girls of 10 to 17, 18 years coming to maternities to deliver. And it caught my attention when a girl of 10 years came to maternity to deliver. And because of her age, she was not able to deliver normally. A CS was done, and due to complications, I think the baby was also preterm, and also the doctors said that the uterus had also to go. So it was a painful experience, and I realized that now this issue must be taken seriously, and that is when now we started championing against teenage pregnancy in Murang'a County. And I want the person who is running the slides to go to the next slide. Just an introduction, Murang'a County is one of the 47, and it is one of the 5 counties in the central region, which neighbors Nairobi to the north, Nyeri, Kiambu, Nyandarua, Kirinyaga, Embu, and Machakos. And we have 7 sub-counties, namely Gatanga, Kandara, Maragua, Madioya, Kangema, and Kiharo. And we have quite a number of health facilities. We have 32 health centers. We have 8 level 4 hospitals and 126 dispensaries. We also have private hospitals. We have 4 faith-based hospitals, and we also have 2 private hospitals. And next slide, please. Next slide. Okay, good. Girls were delivering in the maternities. We decided to start a program we call Okoa Teenagers Initiative. And we did this to mitigate and intervene on the increased number of teenage pregnancies, which were being recorded in the antenatal clinics. And this formed the basis of working towards reversing the trend. The efforts initially were focused on the lower Gatanga sub-county, which largely is semi-arid and was much affected by the menace. I remember on the year 2017, I visited a health center called Gilelia, which is in the lower Gatanga. And that particular facility in that whole year had 146 teenage girls who had delivered. And I had a meeting with all of them. They came with their babies. We had a discussion. We listened to them. And I was able to see the trauma in their faces. Young girls who are mothers, they are not, they cannot be told to go back to the children, and also they cannot go to older mothers who are married and they have children. So I found a misplaced lot who needed help and who needed interventions. And from there, I decided that now we have to do interventions and outreaches, which were later rolled to other sub-counties with greater success through the scale up of these activities. Sometimes we could get problems because of limited resources, but it's an initiative that we do even today. It's ongoing, and we are not stopping yet. Next slide. Now, if you look at the trends, in 20 years, and we as a society have actually accepted that it is normal for 10-year-olds and up to 14-year-olds to come to maternity and deliver. Now, this trend, when I was looking at it on the face value, even without the data, by just following in the maternities, how many children have come to maternity to deliver, you would find that the data is there, raw data of the patients who have actually come to deliver. And you would even identify and find out who are these girls girls, where they are coming from, where are the parents, and would really want to say in this meeting that one of the things we have discovered, majority of these girls actually come from very poor families. Others are from being brought up by grandparents, where the mothers and probably the parents are away. And others are pure cases of adults taking advantage of children. And you can actually see from that age group, when we started this program of Okoa teenagers, the numbers have been going down. And also, when I look at now the real numbers data on the ground as I go around, I have found that the pregnancies between the age of 10 and 14 have tremendously gone down. And we are finding now a few cases for 15 years, but where we have now a biggest problem is the age of 16, 17, and 18. But with our program, we have really been able to talk to the teenagers, we have talked to the parents, we have talked to the men, and we can see it's bearing fruit. Next slide. So the campaigns we are doing right now, because of the advent of COVID-19, we are doing a lot of COVID-19 sensitization. We are doing HIV. We are doing testing and linkage to treatment, including education and distribution to eligible participants. We do pregnancy screening. We screen and treat STIs. We give condoms to the ones who are eligible. We sensitize on alcohol and substance abuse, and we give sanitary towels to promote hygiene. We also teach about contraception services, because we don't want those girls also who have become pregnant to get another pregnancy. We also do HIV education and prevention for those who have been access, and we do this depending on age, and when you in age groups, so that we make sure that we target the message that is required, because we want even to talk to the very young ones of 10 years so that we are able to sensitize them on what they need to be aware and the dangers that they can find them, how to prevent and to manage in case they are affected. And then we have linked support services to the survivors, including legal services, using the community health volunteers. Next slide. And in our championing, we use the office of the CC to spearhead this campaign. Of course, I'm the champion. I'm the main champion of this program, and I use this Department of Staff with a lot of support from community health volunteers. I've been using Ministry of Education because we have to visit schools and talk to the girls. We've been talking to teachers as well. We use Ministry of Social Services, where we really need support, especially if a girl has to go back to school and the child needs support. The Department of Youth, we use Children's Office, especially when there are cases of defilement where children need to be protected. We use the Office of the County Women Representative. We use the Kenya Police Service because of recording of statements. We use the judiciary because of the cases. And then mainly the Ministry of Interior and Coordination, mostly chiefs, sub-chiefs, and village elders. Now, while we are still on this slide, I think it's worth noting that when we get to a case where a girl has been defiled, the first call is the hospital where the girl is examined. And then we go to the police and report. Then from there, we get to write statements from the child who is affected. After that, we start looking for the perpetrator with the police. And once they are arrested, of course, we take them to court. Majority of the time where there is no pregnancy, the cases have been very difficult to deal with. But where we find a child has been defiled and a pregnancy came in the process, those cases are very easy to prove, because when the child is born and we do DNA, it becomes easy for us because the perpetrator cannot run away. But where there is no pregnancy, the defilement case now, it becomes the burden of the child to produce evidence in court to prove that it is indeed that man who did that to her. We have succeeded in some cases. Others have failed because of lack of enough evidence. But the judiciary has been very supportive. And when a child actually confesses in court, some of the judges have really been very helpful and have taken that evidence to be true, and men have been jailed. I have also had some challenges with chiefs and sub-chiefs who form those kangaroo courts at home. They sit down with the family of the perpetrator and the family of the girl, and you find they actually rob the young soul justice, and they agree on a certain way of support when now this guy realizes that now time has passed. So those are some of the things that are quite challenging in that. I'll give you more examples as we go on. Next slide, please. Achievements of Okoa Teenagers Initiative. We have managed to bring back 6 breastfeeding teenage mothers to give them support to resume school. We have rescued defiled teenagers to safety. I have personally gotten involved in supporting those girls in terms of having their cases heard and determined. One of the challenges I've seen in this is that some of those girls, when you tell them to come to court, they have no money even for fare. So I have gone out of my way sometimes to even pay fare for them to come, because I don't want the cases to fail simply because somebody did not appear. And since 2017, when we started, late 2017, 2018, when we started this, we have had that one cases concluded. Two cases of defilement. And one of the things I've realized is that when we continue doing this, we even get some teenagers who are HIV positive. And in the recent one, we really got 3 teenagers who we identified as positive. So you can see the magnitude of the problem we are discussing here. Next slide. This particular case is a girl who is 16 years old. This girl was defiled by a teacher, and the teacher gave the father 50,000 shillings, and the teacher went and offered the police 150,000, because he knows very well that if the case is hard, there's no way he is going to run away from it. Now, after 1 year, this girl came to me. Now she's now 17 and a half. She has a baby who is 1 year old from this teacher. And the girl is telling me, Mheshimiwa Mimi, I need my justice. I need to go back to school. My father colluded with the police and they gave money, and this teacher promised to support. but now he has disappeared. I have the baby here and there's nothing I can do. So when I went to the police, I realized that the file had disappeared. So we have constructed a new file right now, and this case is coming on, and sure I'll be updating the team on how far it's going, because I'm sure these meetings will continue. But such cases are many of girls who get defiled and they don't get justice. So next slide. Yeah, in this slide, we were at Mitubiri Primary School. You can see there is a nurse talking to the girls, and when we do these sensitizations, we actually separate the girls and the boys so that we can give them targeted messages. And I have a team of community health volunteers, psychologists, nurses, and counselors who I have built in this group so that every time when we go, we are able to deal with all the cases. Here, we actually screen all the girls, whether they are pregnant. And in this particular group, when we did screening, we found 3 girls who are pregnant. And they form some of the cases which I'm following now in court, because I realized one of the girls actually had been impregnated by a man of 52 years, and the girl is 17. So you can see it's a clear case of an adult male who even has a family and has decided to move out and go and spoil somebody else's child. Yeah, next slide. Next slide, please. Yeah, same. Now these are the boys. We also talk to the boys. We talk to them about sex. We talk to them about alcohol and drugs. So that we also make them aware. We also train the boys to know that the young girls they see around, they are their future wives. So they also need to be protected. So we are also sensitizing our boys to learn to protect their future wives. And it's a discussion that is really helping when we tell the boys the things they need to be careful about. And in this particular picture, I was in SCK St. James, where I had just talked to initiates. Now, in our culture, initiation ceremony for men is really taken seriously. So when I talk to initiates, we are able actually to explain to them the dangers of engaging in premarital sex, the dangers of getting HIV and diseases. We teach them about even the dignity of staying without sex until the right time. And we also clear the myths. There are so many myths that these young boys after initiation, they are told by their peers, by their mentors, who some of them happen to be older than them maybe, and because they are their mentors, they will start giving them the wrong information. So we make sure that they get the right information, so that when they go out there after circumcision, they go to face the world knowing that this is what to expect. Next slide. Yeah, this one was Gatura Catholic Church, also initiates. I was talking to them about drug abuse, substance abuse, and also sex. I'm also talking to boys about teenage pregnancies, because it takes a man and a woman to make a pregnancy. So why we have decided to be talking to the boys is because when we did our research, we also realized that out of the numbers you saw in the first few slides, the 6,000 pregnant girls, the 7,000 pregnant girls, we also realized that 36% of those pregnancies are from peers. You find it's a girl of 16 years with a boy of 17 and a half or a boy of 18. So we are making these boys aware that they can become fathers without them knowing at this age. And we are also showing them that that is very wrong and it is dangerous and it can derail their dreams. So we really give them that information and sensitizes to them. Next slide, please. Yeah, in this particular one, I think I'm the one there. I was talking to the community health volunteers. Here, I was advising the community health volunteers on what I want done, because we normally do meetings. We do pre and post analysis of every meeting that we undertake, so that we invite also parents of the pregnant teenagers, and then we get all the information, where the girl lives, how this happened, who is responsible, and then we take notes, and then we are able to follow up with parents. And I must say at this juncture that we have also found that some parents are very adamant and very uncooperative. I want to tell you of a case where a 14-year-old girl was impregnated by a friend of his father, and then the father was given 50,000, and then the man promised to be giving them 7,000 every month. And as the pregnancy progressed, some 7,000 were not forthcoming. So the mother of the child was not aware of this. So when the mother realized and asked the girl confessed. And I also go to radio to talk about teenage pregnancies. And at one particular time, I was at Musi FM, the Kamba radio, and I talked there, and this mother heard me say that if you have a pregnant girl who is at home and you feel that justice has not been done, please call this number. So I gave my number, and this lady called me, and we discussed. I made them write a statement with the girl, and the man was arrested. So when this man was arrested, the father of the girl, because he had eaten 50,000, that night he went and beat his wife very badly. So the following morning, the wife told me, and we also opened a case of assault. So the two cases ran together. But when I want to say that the magistrate who was dealing with that case, actually, when she realized that this particular mother was being beaten because of protecting a teenage girl who has been defiled and made pregnant, in the ruling after 6 months, because the case was very fast-tracked, in the ruling, the father of the girl was jailed 7 years, and the man was jailed 20 years. So those two men are in jail right now, I think in Machakos or somewhere, because that case was in Kitimani court. And we really have parents colluding with the perpetrators and getting money and making sure that that one is lost. Next slide. Yeah, this is Idanga, Lower Gatanga, where these girls had been mobilized. Now here we were making them line up so that they can go for testing and sanitary distribution. Next slide. In this one, this was Kahuya Girls. I had a meeting there with almost 2,000 students after talking about sex education, after talking about drugs and alcohol. We were able to give a few girls some sanitary pads. Yeah, next slide. The same meeting, youths from various schools in the county, we had congregated them at Kahuya Girls. Yes, next slide, that one is clear. Now, this is my team of community health volunteers. This team is basically in the Murang'a County government, we have 1,500 community health volunteers who are allocated what we call community units. And each one of them has homes that they visit. And I pay them a stipend of 4,000 shillings per month. just to motivate them for airtime and for small movement. And I always tell them in a week, if they can visit their homes within a day or two, that money is not enough, yes, but it's a good start. And we, in this particular meeting, we were training them on how to follow up on those teenage pregnancies. And community health volunteers have been very useful in this Okoa Teenagers Initiative. Every time when a girl becomes pregnant, they are the ones who report to us. In my community unit, I have 2 girls, and then so that we mitigate the issue of having them not stay at home without going for the 4 ANC visits, these community volunteers are the ones now who will also help to take those girls for the ANC visits, so that in case one of the girls is HIV positive, then they are able to be linked to treatment so that they don't transmit the same to the unborn child. And one thing you realize, team, is that the gains we had made on management of mother to child transmission of HIV has been actually been brought down by teenage pregnancies, because when you look at the number of teenage pregnancies that are with us right now, you realize that majority of those children now who are born with HIV belong to mothers of that age bracket of between 15 and 24 years. So, and this is because when a girl becomes pregnant, this girl, first of all, will hide. She will not come out and say, I'm pregnant. So the chances of her missing the first 3 or the first 3 ANC visits are very high. And she will only come out when the pregnancy now is visible, when it is seen. And this is an area where the community health volunteers have really helped us, because they are able to identify those homes that have such girls, and they talk to the girls, and the girls are able to open up to them. And now we are able now to take up the cases, we sensitize them. The ones who have HIV, we link them to care. The ones who are bold enough to wait for the pregnancy to term, we make sure that they undergo skilled delivery in a hospital. And also, if their parents are able to take them back to school, we make sure they do that.
If we can begin to wind up.
Yes. Then next slide, please. So in conclusion, I always like quoting this philosopher who said that the world suffers a lot, not because of violence of bad people, but because of silence of good people who keep quiet when bad things are happening. I think as a society, we really need to make a decision. We really need to speak about this issue of teenage pregnancies. Dr. Macharia has alluded that the youth are very vulnerable. They need to be protected. They need to be directed. We are also telling them that as much as they demand all those things, we also train them to be responsible, because even those small girls, before they got to get pregnant, some of them are the ones who take themselves to where those men are. So we are also advising them that as much as you also ask to be protected and to be guided and to be directed, you must also be responsible young people who are not taking themselves to where those dangers that can affect their life is. And with those many words, I think I would want to stop there and say that we really need to take this initiative very seriously. We really need to make sure that we are making the decisions to protect our children. And we also need to agree as a society, do we introduce sex education in school? Do we give our girls contraceptives? Do we, that's a discussion, despite the church resistance, is a discussion that we really need to discuss loudly and make sure that we help these children before it is too late. And the curriculum of education does not have that. So it is us, as the Ministry of Health, to advise and probably also give information where it is necessary. Otherwise, if we don't do that, the Ministry of Education will blame the parents will blame the Ministry of Health, the Ministry of Health will blame the administration, the police, that they are not doing their work, and the children officers. And then at the end of the day, it becomes a blame game and nobody will be able to help them. And that's why I have taken it personally to educate those who can listen and mentor them, to go the legal way and jail those who are criminals, and also make sure that the departments and institutions that have a responsibility are also doing their work. And if we do that as a group, I can assure you, team, we shall win this war, we shall reduce these teenage pregnancies, and we'll have good women who have a good future. Thank you very much.
Thank you very much, Dr. Mbaye. You know, you can hear the passion, huh? And I like the quote you had there in the end about good people keeping quiet. And I think that if we have a society that where health is put forward and health leads, as Dr. Macharia had talked about earlier, that this is a multisectoral effort, but health has to lead. We have to point out what needs to be done. And I think we've had a very good talk, and it's a very good example from the Honorable Dr. Joseph Mbaye. Thank you very much for your presentation. Now, we want to get to the next bit, which I'm going to hand over to Keegan Korir, just to take us through a Q&A session. So presenters, just be on standby. We'll take one question, answer one question each from the presenters will answer one question each, and then we'll hand over to Dr. Ann Kihara for the wrap up. So Keegan.
Thank you very much, Dr. Kari. I think there are a couple of questions which have been running through the Q&A box. But I think I just want to encourage that if we still have questions, please feel free to post them. And perhaps maybe the order that I'm going to take is we'll start with the very, very last presenter, going to the very first presenter. And purposely because the last presentation is still very fresh. So questions for you, Mheshimiwa. One is, of course, really an acknowledgement of the Core Teenagers Initiative in Murang'a County. And one quick one is, of course, the effort to promote return to school, especially for the girls who become pregnant, is one of the best interventions that we can look at in terms of giving girls a second chance. So there's a question on how you manage to balance, the need also to ensure that the babies born by these teenagers actually acquire the optimal growth, bearing in mind the issues around breastfeeding and perhaps also just attending basic care for the children. The second question for you is who funds the DNA? Is it the county? That is actually a question from Dr. Mutini. And the last question, which is just related to that, I think you've tried to answer, is how are you navigating the whole issue of access to contraception by adolescent girls, particularly knowing the issues around consent, when we have barriers around the same and what have you. So over to you, Dr. Harry. Perhaps you can quickly answer those ones, then we can go to the next set of questions by the presenters. Dr. Mbaye, over.
Okay, thank you very much, Corinne. One of the things that we are doing to make sure that those girls go back to school is that when we actually identify that this girl was in Form 2 or Form 3, they have become pregnant, of course they stay maybe 1 year back home, we work with the parents where there's a parent, and where there's no parent, we use our community health volunteers and the children officer, and we actually recommend the girl to go back to school. Where they are not able to pay, we actually take up ourselves and get the bursary. We give them the county bursary so that they're able to stay in school. And right now I have 6 who are on that bursary. And the ones who we have taken back to school through their family's support are 117 right now. We have some who refuse to go back to school. They say that they want to do a course and such. Some of them, we have sent them to our polytechnics, the polytechnics that we have in Muranga, and we actually take them there and train them for free. And some of the courses they are taking are like hairdressing. I have seen 3 girls taking barber training, others welding, others painting, but majority of them you will find them in the hairdressing and pedicure and manicure business. So we really have an elaborate way we are dealing with them. And the other question is, who funds? Of course, when we take them to the polytechnic, any cost, any material
I think we lost Dr. Dr. Richard, can you hear him?
No, I can't hear him. So I think it's gone off. Maybe just go to the next. He'll come back on.
We'll go to the next set of questions before we come back. And so maybe this one goes to Dr. Schiller. I think in your closing submission, you pointed out really to the need to ensure that one of the ways really for us to revolutionize adolescent health is basically adapting what we call sustainable financing. We have so many policies that have come up. I think one of the biggest challenges remain really sustainable financing mechanisms. As someone who has been in, have seen both sectors in terms of being a financier, what is the best way for us to attain this?
I got disconnected, Corrine.
All right, very quickly, Dr. Harry, maybe you just wind up on the question that you can.
Yeah, I just got disconnected. Now, on the other question of contraceptives, our Department of Reproductive Health will normally advise those girls who have already given birth to use contraception, because there is a danger we have noted. When a girl becomes pregnant and gives birth to a child, chances of getting a second pregnancy are very high. These girls are vulnerable. So the Department of Reproductive have been mulling around that, and it's a discussion that has really been fought. But me thinking, I would rather have those girls use contraception, because instead of making them now get a second pregnancy and now start having 2 babies that don't even have good nutrition, they have no money to support, that's a discussion. And then before I wind up, I wanted to bring to your attention that we've also noted that some of those girls even commit abortion. And when they do that, they will not even go to a qualified person. They will use all manner of crude means. So some of them come to the hospital when they are very bad, and we lose girls.
All right, thank you very much, Dr. Shari, for that wonderful submission. I think we've taken note of some of the best practices that are happening in Muranga County. At this juncture, I'll just jump into Sheila, perhaps maybe just respond to that question of financing, and we can take the next level. Thank you.
Yes, thank you very much for that question. I wanted to take an example of a county like Samburu County. Samburu County was considering financing health, and as the complexity was, how do we do this sustainably? And what one realizes is that if you look at the budget process, thinking specifically of the county and the way that Migori has approached it, and perhaps the way Muranga has, is to look at the resources that come under what I'd call the package for the county assembly in charge in terms of the constituency development fund, and then what is coming then into the health sector. And under the different budget lines, it is possible to define interventions or entities that will be financed, that when collectively put together will create a budget that feeds into the adolescent. So in Migori, for instance, and it would be so great if they were given an opportunity to come, it meant that whether you are looking at the Justice Ministry or the Education Ministry, everybody had a particular line item in the budget that contributed to that. When that happens, then year on year, you can see that item then is being financed. Similar to the way at the national level, strategic health commodities have a specific budget line from government. And therefore, whether it's in the MTEF process or the annual budget policy, it is assumed that that line item will be there. That is what would need to be defined, and to say what are the components that when we add collectively together across the sector, translate into resources that can then address many of the things which Honorable CEC has so eloquently described. So I believe here it's a matter of bringing the right people to the table, the CECs who are dealing with finances, the health and the other sectors, bringing the national treasury, and then defining that. And then alongside that, then is to say, then how do you then bring in other resources that come from the community, the private sector, etc. So simple is to identify what is it that translates into budget items that can be considered available for the efforts that a county wants to do. And then year on year, using a very good milestone and monitoring process to see that financing continues, and then to draw in partnerships because there are resources from other sectors. I hope this has helped to answer. Thank you.
Wonderful, wonderful, Dr. I think that's a very good submission in regard to sustainable financing for adolescent health. I think the next question would be around vaginal practices. I think this is, there were a lot of questions around this, but perhaps we can take around two. One, I think, is basically a comment. Is there a way, or that vaginal practices can be considered, for example, as harmful practices that is worth eradicating? The way we look at issues around female genital mutilation being considered a harmful practice. And also, I think there was also an anonymous post here that there's been a lot of requests, particularly within facilities for vaginal tightening, vulval reconstruction, particularly post-delivery. And I think there's perhaps a recognition that some of the colleagues are conducting episiotomies. And the question really was, is there a way that colleagues can be able to really distinguish the two and be able to handle episiotomies differently? And then lastly, for Dr. Mite, is whether vaginal practices have an effect on fertility of women. I think those are the three questions that Dr. you can quickly respond to as we close this. Hello, Dr. Ari, are you there? Dr. You get me? Dr. Can you hear me? Hello, am I audible?
You're audible.
All right, thank you. I think as we wait for Dr. to come back, we will go back to our first presenter, Michael, the year 5 student. There was a lot of recognition of the issues that have come up. Actually, those was affected the students. And the one question from Judith Seve is that she has noticed high number of cases of drug and substance abuse, particularly among medicine and pharmacy students. And particularly a number of them want to drop out on the 3rd year of study. And some of them are performing, underperforming academically. What would be behind this observation? And I think the other one was more or less related to, I think this was the Kenya Demographic Health Survey has been showing that over 90% of pregnant and parenting adolescents are out of school. What need to support these adolescents to go back to school or get vocational training? This was a question to Michael, but I know it has been responded to in a way. But basically, Michael, maybe you can be able to talk about those questions on the upside of drug and substance use.
Hello?
Hello, Michael?
Yes, Dr. Korir, I didn't hear you clearly. Was I to tackle the question?
Yeah, so the question actually for you basically is high upside use. I think there's an observation that actually in among the students in medical. Yeah.
Yes. Basically, the whole idea of the drug and substance abuse among medical and pharmacy students, it's usually more of a coping mechanism because there's this perception where when you actually get to medical school, all is well, but in real sense, people outside there don't really experience the heaviness of the studies rather, because maybe if I can use a simple, or rather something easier to understand, for instances, we actually sometimes have procedures that we need to learn and actually need to be documented on things we actually call logbooks, so that the university can actually see that indeed this student actually attended the session, maybe observed, performed one, and was and actually understood. But now maybe looking at COVID, you're actually limited to schooling hours by the curfew. And sometimes maybe some things which involve going to theater, you'd find students going to theater at night because maybe that's when they're free. You know, there's no clashing of classes during the day. So now with curfew, imagine you do live far and you still need to fill out this logbook. During the day, there's that element of Zoom fatigue, which I talked about. You have to actually follow up with all the classes. You have to actually get that logbook filled. And at the same time, you actually have to make sure that you understand what is actually being taught, not so that you just don't end up really being a quack out there. You want to be a good doctor. And looking at it, again, not all of us actually have the channels to talk about it. You don't have someone to, you know, to share about your struggles unless it's maybe your colleagues. And most of the time you actually find yourself turning to drugs as a way out, you know, something to soothe you, something to break the whole monotony of I'm reading, I'm not doing anything else, I'm reading. And sometimes you can actually find that it becomes more of that fluffy bed that you actually want to lie on throughout and not necessarily face the facts that things aren't really easy. But again, who do I really talk to? What will I actually be judged if I actually talk about it, or will people out there be like, this guy is just being lazy, this guy is not trying hard enough? Yeah. So if you actually look at it like that, drugs looks or rather using drugs looks like the easier way out. And with the current generation, or rather us, the whole idea that you only need drugs, you don't really need to work hard. That's all you need. You'll just find these pharmacy students, medical students, also comparing themselves to their peers who maybe went and did, or rather are doing other courses. So again, just drugs looks like the way out, and also looks like the thing that's actually in right now. Yes.
All right, thank you very much, Michael, for those insights. Really, indeed, we see that, of course, pressure contributes to some of these aspects. So I want to perhaps go back to Dr. Richard. Do we have any further insights from you before we invite closing panelists?
I think we're good. I think we can just invite our panelists to wrap up.
Thank you very much. So without any much further ado, I think it's been really a wonderful, wonderful session. A lot of insights, a lot of learning, a lot of issues to pick up, both in terms of policy and practice. And at this session, I want to welcome Dr. Dr. Kihara Ann will just take us through the final wrap-up for this session.
Thank you, Dr. Richard Iyer. Thank you, Keegan Korir. I must start by wowing everybody. It's been a week where we have learnt, we have cried, we have shared. But I had the hardest task, which I think I've taken it honorably, to actually ask ourselves what therefore is our take-home lessons and strategies that we can use to optimize adolescent and youth using a holistic approach for sexual reproductive health and rights for them. Next slide, please. I'm going back to the beginning, what really brought us together at the very beginning, which looked like a very tall order. And specifically, the objectives that we did give ourselves was to evaluate the epidemiological profile, contextualized to this country landscape, review an interconsultative process, the evidence shared both nationally, at county and in communities, analyze the role of family planning and contraception, one of the biggest debates. That's why I alienated it, to actually make us discuss it, and to see the return on investment when we do use those practices. Comprehend the SRHR issues that plague or afflict or affect not just the adolescent and youth, but extending to households and beyond. Create and strengthen a multi-stakeholder and multi-sector collaborative partnership, and to interrogate our leadership and governance within the socio-ecological model for both adolescents and youth of this country. Next, please. So the methodology we have used all week long was this webinar, and we have consulted far and wide, used a multidisciplinary and even a multi-sector approach. So people brought in evidence, peer learning, identification of complementary approaches that we can use, and interrogation of therefore, what else can be done? Next. So in essence, when I thought more about it and as I prepared the panelists to come and speak to us, I couldn't help but want to take a dive into a theory of change. So we have government officials, we've had partners, we've had public-private come and speak to us, we've had healthcare providers who have been integral in these processes. But above all, we have had the community and even the voices of those who are affected. And our aim is basically to give changing of lives, and not just a change, transformative change for the Kenyan adolescent and youth. Next, please. So who has been our audience and what has the attendance been like? Section A, which was the very first talk we gave when we were doing the introductory, we had 539 participants. This is a median. Section B, which was late evening on the first day, was 204. Section C, which really addressed issues of teenage pregnancy, HIV, family planning, you can see it shot up to 637. Section D, which was yesterday, we had 564. And Section E, which was yesterday evening, which addressed advocacy, we had 169. So overall, you can see the attendance has been very high. And it has been a cross-section of different people bringing in different voices and evidence. The government, represented here by the Office of the President, the Ministry of Health, and other agencies. Donors have been on board and partners, public and private partners, healthcare providers, academia and researchers, civil society, and the adolescents and youth. And here I'll even beg to add, we've had communities even from the region and globally tuning in. Next, please. Areas that we've covered. We have covered different aspects, but we started very far from epidemiology, moved on into menstrual hygiene management and menstrual health, normal and abnormal menstrual patterns, unsafe motherhood. And when I say unsafe motherhood, I personally believe teenage pregnancy is a gender-based violence. Together with gender-based violence, STIs and HIV, childhood marriages, FGM, reproductive cancers. We've also looked at social-cultural harmful practices, mental health, substance and drug abuse. We looked at nutrition and NCDs. We've looked critically at advocacy and which way it ought to take. for this age group. Accountability, and then the legislature, policy, and programs. I must say, this age group has physical changes, emotional changes, cognitive changes, and social changes happening. Initially, where you were a child and you were being nurtured by your mother, and you really were under the dictum of your parent, it changes in this age cohort and transits them into adulthood. I must say, one thing that we don't seem to be discussing is also the brain development of these children. And when you did ask my young student, I will add on his speech, the brain does not mature until you're about 23 years of age. But from puberty until that age, there is what we call brain plasticity. You will be grooming certain neurons and synapses. You will be also cutting off other synaptic issues. So if you groom to be sexually active, it is a positively reinforced thing. If you groom drug use and drug abuse, not only are you grooming the wrong kind of pattern in your social livelihood, you're also ruining the possibility of the brain to have that cognitive decision-making that is constructive at age 23. So you end up now picking a habit that becomes a persistent habit. And as per the talks from the mental health doctor, it was very clear. The vulnerability is hardest and worst the younger the age. As you now move closer to 23, 24, it tends to get stronger in decision-making that is less irrational, but more constructive. Next, please. So I love this slide because it's done by UNFPA, but it really depicts what we've all been saying. The justification for this talks from Monday to date have been the issue of achieving demographic dividends. Keep the person healthy, keep the person in school, get them to have a good education, to be able to enter into labor markets competitively and more so in the global arena, to be able to earn an income and have safety nets with money. And if you look at the red line below, a young girl at age 16, Honorable has really given us the Muranga story. Age 16, the probability she falls out of formal education, gets repeat pregnancies, and I've always said this, once pregnant, one leg is in the grave. It doesn't matter how old you are. You're carrying another person, but you are at risk of medical issues, also compounded obstetric issues. Unfortunately, it is worse the younger you are. Now, not only will you end up losing your potential to be healthy, you're losing your potential to be educated. You're losing your potential to gainfully earn an income. So the top green one actually shows us a person who's retained in school and how you have the work-life balance, you have safety nets, and therefore are able to achieve demographic dividends. The in-between, between the red and the green, we all know what needs to be done in terms of comprehensive, age-appropriate, comprehensive sexual education. We know we should be putting in family planning and contraception. We know we should be giving you education. If you miss out on formal education, can we give you the informal, the technical, vocational training so that you have a skill set to still earn income and change from the discourse of abject poverty? Ladies and gentlemen, as I move from this slide, I want you to remember only one thing. We are responsible for the quality of the Kenyan citizenry for tomorrow. Every time a woman is pregnant, I think we need to put her at the top in this country. Next, please. So what are the lessons? And this is where really I was challenged, but I took the challenge. Lessons learned and strategies, and I've basically classified them into 4. I said we must engage. So assume my adolescent and youth are in the middle. We must engage, and I will elaborate on each one of them. We must accelerate and stop hiding like ostriches with our heads buried in the sand. It's not happening. The evidence is already out there. We must align and we must be accountable. The arrow at the bottom depicts in the continuum of our life discourse. It has to be a continuum. It doesn't start with motherhood and having a pregnancy. That baby will be born. How do you deal with that child? How do you deal with that child becoming an adolescent and move them through the reproductive years into an elderly person in a dignified manner? Next, please. So what did I gain from the Engage that I listened to from Monday? And knowing that the COVID-19 unmasked to all of us all the underlying problems. What should we be doing? The adolescent and youth must be at the core, and they must be there. All policies, when we talk of health in all policies, they must be there. The strategies, the programs, because it affects them. And they are the generation taking leadership from us. Number 2 is priority setting. They should be there in the design, planning, implementation, monitoring and evaluation, and decision-making. I've underlined decision-making. It's come up very clearly. We must have multi-stakeholder and multi-sector. We must leverage on this beautiful partnership that I must say for the first time we have actually engaged in through the webinar contact. We must have lessons and benchmarking from others' experiences. I've learned so much from Migori, from Samburu, from Murang'a. These should actually be scaled up and contextualized for each county, but at least there are lessons we can learn from. Technical support. I must say, Korir, the outpouring of evidence that has come out, I couldn't believe. It was not just the universities, it was academia, it was researchers, it's private institutions in this country. The wealth of information is there. Peer-to-peer exchange must be upheld. Engage national and county leadership to cascade all the way up to the household. People need to be informed. I put this in capital. Everybody is crying. Parental engagement, role modeling, mentorship. Where is it? These are our children. These are our adolescents. These are our youth. Where are the parents? We must provide safe spaces. I felt very bad when I was listening to Murang'a and he says, not only was the wife GBV'd, the baby was already pregnant. So 2 girls in his house have got something they'll carry for the rest of their lives to provide not just basic needs, but a haven for that child who is now 1 year old. So where is the safe space? And I must say, Honorable, I'm really impressed that you are going in the driver's seat. School programs came out so clearly as significant learning areas for adolescents and youth. Therefore, my question became, if guidance and counseling is already in schools, should it just be a passive program or should it be examinable? Should we think of reintegrating? And even we learned yesterday, there is a reintegration policy document. Yeah. And if not, then can we offer apprenticeship skill set so that we have girls, even if you did get pregnant, you're still going to be able to provide basic needs for that baby and also support yourself so that we don't go into the decadence of repeat pregnancies because of dismal, abject poverty. And then media engagement. And I've said there, everyone has a role and responsibility to protect and nurture adolescents and youth in this country. Next, please. So we move from engage, next, and move to accelerate. And I want you to pay attention to the arrow. I don't want an acceleration, Dr. Aya, that is, just plateaued. We really need to move like a Concorde. COVID has definitely changed our performance indicators in sexual reproductive health. And it's everything. It's not just the teenage pregnancy. That's just a front. It's just a manifestation of unprotected sex. There is STIs, there's HIV, there is mental illness, there's malnutrition. So it's a whole cascade of a lot more. So when I say we take a Concord, how will we do this? We have the universal health coverage program in this country, with primary health care being where we want to do fundamental basics. And we're saying we should be the forerunners for health promotion and preventive strategies. A teenage pregnancy is too late. We should be preventing it from the first place or in the first place. Health promotion, preventive strategies. And the new concept of self-care. Can we train our children to have life skills? And the only way you can do that is give them health literacy, what the Honorable is trying to do. Self-advocacy, really holding yourself in self-esteem and saying, you know what, this isn't for me, it can wait. And being self-organized into action. That's the self-care we talked about yesterday evening when we talked about advocacy. It starts with me and then moves to you and then moves to us. So in this part, I'm actually saying what we need therefore to do as per our conversations. A robust health system. Where should they get their service delivery points? Is it a one-stop shop? What are the hours of operation? And within the community, are you giving mobile services, outreach services, telemedicine, using the M platform? Are we embracing public-private partnerships? And what then constitutes the minimum health package for them? Then, reducing the inequalities and iniquities, because we're not the same. Urbanites, urban informal, rural, even per geospatial orientation in this country, we have issues. But all of them need to get information, education, communication, access to products and services. And to remember, in each of our jurisdictions, there are still more vulnerable people and marginalized populations. Social determinants, we cannot ignore this element. And I put poverty and illiteracy as our biggest obstacles. I think even Dr. Sheila alluded to this. These are our biggest obstacle. How are we addressing those? But again, it has to move concurrently or in tandem with looking at nutrition, wash, and retention in a school educative program. Next, please. Financing. This I've heard, and Sheila even alluded to it. And I will even add, we have so many sectors that are represented in this room. Why are we still siloing our programs? Why can't we actually do an intercollaborative program where even pooling of finances will come to play? Why can't we invite the private to actually engage all the more with public? We only get the one-off, the philanthropic groups that are in this nation. It should be a standard. We have this issue. This is our priority. For example, this is our priority in Murang'a. So once you give the context prioritization in a county, then funds will definitely follow in the same tandem over and above what the government can give. Because we don't expect the government to have a bottomless kit, yeah? But the other converse is this. Should we think about cash vouchers, especially for this age group? And as articulated by my student, Michael, they are stuck, can't get basic needs, food, shelter, clean water. Are we seeing that? Social livelihoods. People's jobs have gone. People are at home. What's really going to happen? And what are the safety nets that Kenyans should seriously be thinking about? Then community engagement and mobilization, and being responsive to the needs of adolescents and youth. Elimination of harmful practices. You've heard about vaginal practices. You've heard about teenage practices. You've had about abortions. But can we change? Because now this is changing the mindset and say, let's uphold positive culture, because not everything is rotten. And I've even put here, can we utilize culture, sports, and healthy recreation to even impart sexual reproductive health, life skills, and messaging? What is the autonomy and rights of these youngsters? So the question came up, and I think, Korir, you even asked, what is a minor and who should give consent? Vis-a-vis, who is the emancipated minor? That came up severally. And what is the age of consent? Where is the voice and agency of civil society? We talk about having embraced it. Are we actually operationalizing it in all counties and even to the national level? And are we really addressing the community demands? Let's move next. Next. So I believe this is the most important. Research comes in tandem with development and innovation. Data has been extensively shared, and notably within the various programs. It's still siloed. And these are the challenges I want to throw to all of us. Some came from you and some I've added. Disaggregated data by age groups and gender and geospasticity. I'm even beginning to think, is really the women reproductive age 15 to 49 correct? Or should we be speaking about 10 to 50? And if I add artificial areas of reproduction, maybe I'll even extend it up to 70. I don't know. We need to have food for thought here. And unfortunately, this is giving us a lot of missing data. It's not being captured because we're assuming the age of reproduction starts at 15. You have heard, it's not from me. Even the Honorable is saying, I'm dealing with 10-year-olds, 16-year-olds, 14-year-olds. Ladies and gentlemen, can we wake up? Key performance indicators, including aggregated indicators. You know, we keep on talking maternal mortality rate and ratio, infant mortality rate, neonatal mortality rate. But ladies and gentlemen, we're now moving from that and actually saying, if you're going to speak development, you must talk of aggregated indicators, things like the Human Development Index, the multidimensional poverty index, because that gives you a more holistic approach into looking at how are we performing. Evidence-informed practices come from data. It informs policies and it informs legislature and it will inform our advocacy. And we can only innovate if we have very clear data. And this is operationalizing it so that you're talking about implementation science, not just this is good, put on the shelf or published and it sits there. That's not good enough. Now, let's move to what's current. Use of big data. I would want, and I'll challenge Dr. Sheila Macharia, by virtue of where she is. Take Ministry of Education, take Ministry of Health, take Ministry of Agriculture, take Ministry of Finance. Put all that data together and say, okay, let's look at it for the youngsters. How are the finances moving in that direction? And what is the data telling us? We have to explore big data and we have the skill set. It's in this country. And go on to do artificial intelligence and machine learning. And even deep learning, the deepest deep learning. Why? That's the only way you'll unravel the mysteries to be able to get sound, homegrown, contextualized solutions. Data is not enough. You must move it to digital platforms and have ownership of data. It's amazing. As an academician and researcher, we're constantly doing what I call projectosis. Richard Aya is attest to this. Projectosis. I'm in a place, collect the data. I don't even disseminate or let the community own it and say, you know what? You're actually telling us a naked truth. What can we do about this moving forward? So the dissemination into communities for them to own it and act on it Believe you me, I want to believe we can get solutions from the communities because they will have owned the processes. The young people must be at the decision-making table to influence this change. Next, please. So my next was align. Let's align. And our alignment now is going to change. And we are saying adolescents and youth must come first, recognizing that's the generation that's giving the citizenry for this country. That's the generation that's giving the development agenda for this country. Yeah, they are a special and unique group, but they ought to get also individualized care. Isolate them, get to the bottom of what is it for you that's challenging you, but also give them positive social change. So they're social networks. I feel very sorry. The majority of them are on the internet and on social media. But what is the quality of information we're giving them? Can they make sound decisions that will affect themselves, their next generation, and as them as grandparents? I don't know. But all the same, we're saying nobody should be left behind. National and international legislature, Sheila alluded to commitments we have made. I remember we were in one forum with her in the AU addressing rubber stamping the community strategy. But beyond that, the operationalization of our policies and programs and learning from monitoring and evaluation and being accountable. Context can never be the same. What I will see in Murang'a is not what I see in Nairobi, is not what I will see in Coast, it's not what I'll see in Homa Bay. That came out very clearly. But we need to have a forum where this comes out, to appreciate our differences, but it's in diversity that learning is actually catalyzed. Be sensitive to gender disparities, vulnerabilities, and marginalized groups. Conducive environments must be provided for information, access, and services. Communication strategies should be in a language of understanding, using different communication channels, and this engages media advocacy. Health promotion and primary prevention should be key. But where you're doing interventions, can we have a multi-purpose intervention? If I'm sexually active, prevent it from causing me added problems. If I'm abstaining, how do I uphold that abstinence? We have to be multi-pronged. We can't be fixated as to what they should be given. It's what do they need? We supply according to their needs. Then partnerships and networks. Healthcare providers becoming empathetic and with the correct attitude. This came out very, very strongly. Our attitudinal change is required of us. Next, please. And then transparency and accountability, basically monitoring, evaluation, being accountable, and also learning. We're very good at dealing with the supply chain. What should the health system give to this adolescent and youth? We need to stop and think and listen. What are their demands? Yeah, and I've said here, what is not documented is not done. What is not analyzed it remains debated. What is not decided upon, there is inaction. What does not become a priority in policies, resources, and systems strategies become irrelevant. Communities need to own their health and be accounted to by duty bearers. That's supply and demand equilibrium. We must think out of the box for homegrown solutions, art and culture in public health. I'll repeat that, art and culture in public health. We are ignoring a very important element, yet we are so endowed as Kenyans. Leadership and governance at its best is always evidence-based practice. Evidence should be at the top. Next, please. So we have quotes from this symposium. I'm an obscene gynae. Where can I act? I was somebody who has been tuning in and I've been following. and has persistently commented also in the chat box, it's a concern. Now I understand why my drug addict is behaving the way they do and can get help. I have learned a lot. The blending of science and patient experiences and our role as duty bearers. This has been an eye-opening symposium. Where did you get such great presenters? I'm learning and I will keep logging in. These are just a few snapshots of what's been going on. Next, please. Time is ticking. SDGs are less than 10 years away. But I certainly believe, without a doubt, if we can say, you know what, Kenya, let's just focus on this youth and adolescent group who happen to be the 30 to 40, in some counties, 50% of our populace. Using this holistic approach, and with all the learning that we have gotten outside of even the medical turf of SRHR, broadening the horizon, we can edge closer to our targets. But what should we have? We must act on the evidence we already have. We must be continuously updating it. We need to get the clinical expertise, which have been in this forum. Different sectors, different technical assistance. But above all, don't forget that the patient's values and preferences and perceptions of what they need also must be fed into this to give you the best practice and get us closer as Kenya and Africa to SDG attainment. Next, please. Finally, I really can't go without acknowledging one, the government is here. The government is very well represented here. We have had the Ministry of Health. We've had the President's Office. We've had many people. And we really want to appreciate and acknowledge their time. Some have been here from Monday up to now. Donors and partners, development partners, you are here. From UNFPA to UNESCO to WHO to USAID, you have been here. Public and private, you are all here. Right from the opening day to date. Healthcare providers, this is a forum where I've actually stepped out of the box and said, we're not just going to deal with COVID data. Let's do something differently. I took on the challenge and I asked Dr. Kinuthia, it may sound wild, but I want to do this. Take a different outlook and see whether it will make a difference to open our minds from the cutthroat medicalizing of medicine. We keep talking to ourselves. We have to talk with everybody about everyone. And I thought this was a great window of opportunity to begin with the adolescent and youth. The academia and researchers have had an outpouring of evidence beyond even my own imagination. The civil society is here, NGOs, CBOs, professional associations, universities, north, south, east, west, they've all been onboarded. The people we're talking about, the adolescent and the youth, they have been here. We have heard their voices. We have heard their stories. We have heard what they're demanding of us. The participants, I can't speak more. I actually feel like we've had an international conference with all of you. The presenters, kudos to you. Less than 2-week turnaround and you've given me sensational information. Kudos to you. You have done it. So I want to acknowledge each one of you. And lastly, my last slide. Lastly, I'm calling for a paradigm shift to act. We have hopefully appealed to your hearts, appealed to your heads, and appealed to your hands to do. Let's get off this high horse of just talking, forums, and another day continues. Let's act. Thank you very much.
Thank you very much, Dr. Kihara, for that very good and comprehensive review of the whole week's program. Like you said, you probably had the toughest job going through everything that has happened every single day. On behalf of my co-chair, Keegan Korir, I would like to thank today's presenters, Michael Malombo, Dr. Mitei, Dr. Shabibi, the Honorable Dr. Joseph Mbai, and of course, Dr. Ann Kihara. Now, very often Africans have a problem with time. We complain, but I think this afternoon and probably the whole week, it's been a very useful use of time. And therefore, as I hand back over, we need to just think about all the lessons that we have learned, the things that we can pick up, and the things that, as Dr. Kihara says, that we need to do. So thank you very much, and back to the organizers. Dr. Kinuthia.
Thank you very much, Dr. Aya and Dr. Korir. We want to really extend our gratitude. I would wish at this point to call the head of my department, that is Professor Omondi Ogutu. And Professor Omondi Ogutu will then call in Dr. Bashir, who is with us from the Ministry of Health. So over to you, Professor Omondi Ogutu.
Thank you, Dr. Kihara, for a fantastic job done. From Monday to date, we have had sensational presentations, sensational discussions, open-ended, lots of information, and it has shown the depth and the wealth of knowledge and experience which is available within the Kenyan professional bodies. This has been a very, very interesting session, which cuts across all the specialties in the reproductive health. And we know that looking at the aspect of the management of the adolescent, it is us who, if we mismanage the adolescent, then we will have no future. It will be us to blame. They will be the ones who will be busy blaming us. The presentations which Dr. Kihara and Dr. Kinuthia had put forth cut across areas of research, areas of community deliverables, looking at moments of concerns of the adolescents, looking at moments of bringing up the families, looking at bringing up the healthcare providers, both at the lower tiers until we reach the top tiers. And this has brought everything in a nutshell, that adolescents are human beings and we need to look at them holistically so that we are able to bring up something which we will be able to be proud of. I would like at this point to encourage the team to be able to organize more and more sessions like this, maybe on a quarterly basis, cutting across all the areas of the adolescent and reproductive health, since there's so much being done every day, and this will ensure that much more information is available and we increase our knowledge. The Department of Obstetrics and Gynae at the University of Nairobi, together with, if we can't be able to collaborate with the other similar departments in the other medical schools within, but as of now, our team has taken the leading role of ensuring that all the information is dispersed, disseminated to the whole of our specializations in all the different specialties, which in a nutshell come together to manage the areas of the adolescent health. This is one area where nobody can say that I have got the whole mandate. No, each and every person has got their bit, And all this is put together to be able to improve the healthcare of our people. Once again, kudos to all the presenters, and kudos to Dr. Kinuthia, and more so Dr. Kihara for putting up a very excellent presentation. And as we all know that Dr. Kihara also wears different hats as the president of the AFOG and also an executive member of FIGO. So with that, she brings in lots and lots and lots of experience in that area. At this point, I would then want to invite Dr. Bashir, who is the head of the reproductive health in the Ministry of Health in the government of Kenya. Welcome, Dr. Bashir.
Thank you very much, Professor Omondi Ogutu. Correction, I'm the head of the Department of Family Health, where the Division of Reproductive and Maternal Health and also Adolescent Health fall. Honestly speaking, this is an opportunity as a country for us to share a vision for this, we can say are neglected in some way. This symposium, as many people say, is an eye-opener to those who don't know. But for us who knew what is happening, it is an opportunity to fast track the slow progress of issues around this age cohort. And especially the presentation, I just came in at the presentation of Dr. Ann Kihara. It's very sensational and to the point. So could we use this symposia as an opportunity to put in all those things you've said, the structures and the partnership into place? As we mentioned, the government is just able to do as much. But this is an agenda for the whole country, and I am sure all the stakeholders are here. They have all been enumerated, and they have all shown some zeal to really deal with this issue. This is the future of this country. And as the head of the Department of Family Health, I am of the opinion that we should review our priority lists and put this age cohort at the top. That's the only way we can achieve progress. Time is ticking. In the sense, it's also ticking for those age cohorts, for those individuals. Many lives have been lost, not really dying, but socially dying. I've been to Kilifi a few weeks ago with my team, which I'm proud of here. Dr. Kaliti, Dr. Ann Mwangi, Dr. Rose. We've been there and we have seen it live, and it can't get worse anywhere in the world. As a country, we have the resources, we have the know-how, and we have the opportunity to work together to ensure that what we talk here, it doesn't just become a talk show, but it becomes really something we can implement. I, as an individual and as a professional in this arena, together with my team, are more than willing to facilitate any of our stakeholders and also the structures to be put in place, and for us to fast track these guidelines and policies that are lacking. Above all, it should be a multi-stakeholder, multi-sectoral approach, since it is just not a health agenda. It is beyond health, it is in education, it is in parenting, it is in issues of social protection. And therefore, ours is to say thank you to Dr. Kihara, Dr. Kinuthia, University of Nairobi, Professor Ogutu, Kenyatta National Hospital for this opportunity, but let us not lose this opportunity and go back to our daily duties. Let us pick it up from here. You can be in what do you call, in partnership with my office and my team. We are more than willing to give the guidelines and the leadership required, and we take it up. And next year, when we have such a symposium, we should be talking about a better place for the adolescents and a better place for this country. With those few remarks, I wish to thank everybody who organized this symposia, the contributors, the presenters, the participants, and the stakeholders and the people who supported these activities in kind or in financial mode. Yes, government is here. Government has shown it as a priority, and we want our stakeholders to work with us. With those few remarks, I want to say thank you, Professor and Dr. Kiara. Back to you.
Thank you very much, Dr. Bashir, and thank you for opening the doors. I will knock, and you know me, I don't stop. But I also want to appreciate, and I know that she said she's coming here in the official capacity as herself, but I think she has the message. Dr. Sheila Macharia, please do the needful. Maybe you can say a word or two before we actually now wind up. Sheila?
Yes, thank you very much, Dr. Kihara, and all the distinguished professors and experts on this day. For sure, listening in the last 4 days, the passion that has been expressed here, the commitment and the concern is real. The experiences of young people are real. And I think just to echo what Dr. Bashir and you yourself has said, is really that we just need to act. We know what needs to be done. We need context-specific solutions for ourselves as Kenyans. Learning from other places, we have evidence, we can generate more. And we just need to appoint the person, the place from where that will stem. The counties are running ahead, some of them with really good work. And there's so much to learn there. And so anything that is planned must have the county leadership there, because there are cultural models that we can learn there, and there are voices that we can hear from young people. And finally, just to say that parenting is no easy business. For any of you who are parents, I'm a mother of young adult men in their 20s. It is not easy. And right now, with the constraint of the pandemic, it has made things really, really difficult. So even as we go and we consider all the complexities and the challenges, I think let me speak for parents and say something needs to be done, a platform, a place. And I believe our Honorable CEC demonstrated very well how possible that is in Murang'a. So thank you very much. I do say that imminently there should be a report that will be coming out that looked at the impact of COVID on adolescents in some counties in Kenya. And you will find that there's a lot of what has been said today is exactly there. And hopefully these conversations and these platforms can coalesce to real action. So thank you very much, Dr. Kihara.
Thank you, Dr. Sheila Macharia. Mheshimiwa Honorable Joseph Bai, Daktari, please give us a few remarks from your perspective, but also representing a national office. I think it's important that I get you to tell us something. Honorable Mbai, are you there? Maybe he's not. If he's not there, I cannot overlook one lady, Professor Marlene Timmerman. You come with a wealth of experience, even having been in WHO, having been a senator in Belgium, and currently domiciled and operating from Aga Khan Teaching University Hospital and doing extensive research in Kilifi. I'd request that you give us a comment. Is she there? She's not there. Okay, finally, I don't even know what to call him, my co-host, Dr. Kinuthia. It's been an uphill task for 2 weeks. We've worked together with the two co-chairs, that is Dr. Stephen Kaliti and Dr. Anne Mwangi. I don't see any one of them, but I can see they're ably represented by Dr. James Gitonga, who's here. But since Dr. Bashir has spoken, I'll just give room for Dr. Kinuthia to say a word or two, and then we can call it a day.
Yeah, thank you, Dr. Kehara, and kudos to the great work you have done in chairing this meeting together with your co-chairs. We want really to thank you for all the effort you have put. And I also want to echo what you have said, that the time for action is now. We have discussed, we know what we need to do. I think now it's time to go and do what we said. I think Dr. Bashir has captured the sentiment when he said, the next time we talk, we meet, we'll be coming to see the gains which have been made out of what we have done based on our discussions. So with that, I also want to appreciate all the speakers, all the chairs, and all the moderators, and all the participants who have made this symposium possible. Thank you very much.
Thank you, Dr. Kinuthia. So officially I'm closing, but I'm closing one door to open the next. And the next is those who wish to rally together with us. I think the majority of you even have my email. Please communicate with us. We will be sending out a survey, and on that survey, we will definitely reflect where you would wish to put your best foot forward. And that means you're not walking, you're running. So that when we do present everything to Dr. Bashir, we know where we are beginning. We really must act now, remembering how you treat the citizenry called the adolescent and youth, or what they better call themselves, Generation Z. They don't even say Z, it's Generation Z, as I was told today. It will actually either follow to haunt us or follow to say we made a difference in salvaging the generation and quality of the Kenya for tomorrow. So with those big, few short remarks, we'd wish to call it a day and call the symposium officially closed. But please, once you answer the survey that will follow through, that is when you will be given your certificate. So we will request you please take that due diligence to actually fill it out for the sake of completing this exercise and opening the next door. Thank you very much, ladies and gentlemen, and God bless you all. Bye.